Hello everyone, welcome back. In this video, I'll talk about sickle cell anemia and I'll also mention sickle cell pain crisis and its management at the end. So we'll start off with the epidemiology, then we'll talk a bit about the inheritance as well as the pathophysiology, followed by signs and symptoms, diagnosis, and management. So first off, the epidemiology. Sickle cell disease is prevalent in sub-Saharan Africa or in people of African descent. And if you don't know where sub-Saharan Africa is, it's this green part right here, where we also have our not-so-friendly mosquito called Anopheles spreading malaria. So through evolution, it has been thought that people in Africa develop resistance to malaria by carrying the sickle cell trait. And according to a 2017 study conducted in Tanzania, the presence of sickle cell trait was associated with decrease in incidence of malaria cases by 29%. Now, the inheritance. Sickle cell anemia is an autosomal recessive disease. So we'll draw our mom here and our dad here. They're both carriers for the sickle cell gene. So there's a 1 in 4 chance that the child does not inherit any allele of hemoglobin S, then a 1 in 2 chance that the child is a carrier, and a 1 in 4 chance that the child inherits both alleles of hemoglobin S, resulting in sickle cell anemia. And people who inherit one sickle cell gene and one normal gene have sickle cell trait, which are these two right here. So now moving on to pathophysiology. We know that hemoglobin A is made up of 2 alpha chains and 2 beta chains. The problem in sickle cell anemia occurs in the beta chains of hemoglobin A. A mutation in the beta chain of hemoglobin A results in formation of hemoglobin S. Now, more about that mutation. It is a point mutation in chromosome number 6, resulting in glutamic acid being replaced by valine. And this is called a non-conservative mutation, which means that due to the mutation, the structure of the nucleotide chain has been changed. Hemoglobin S is susceptible to sickling in deoxygenated blood, and that's why if we look at the oxygen dissociation curve, anything that shifts the curve to the right will cause sickling, and that includes low pH, high partial pressure of carbon dioxide, and high temperature. And since it includes high temperature, then you can imagine that any infections can result in high temperature and lead to sickling. So what does sickling actually do? Sickling or repeated sickling causes membrane damage of the red blood cells. And this leads to hemolysis. And hemolysis over time leads to decreased oxygen carrying capacity of the blood. And that in turn leads back to sickling. So that's how we have a vicious cycle because of the sickling that occurs. So now, on to the signs and symptoms. We'll divide the signs and symptoms into those caused by extravascular hemolysis and those caused by vaso-occlusive crisis. So first, extravascular hemolysis. So extravascular hemolysis is when the red blood cells are broken down by the spleen. And this breakdown leads to formation of hemoglobin. So you'll have signs and symptoms of anemia. And hemoglobin is further broken down to unconjugated bilirubin, resulting in jaundice or yellowish discoloration of the skin and sclera, as well as cola-colored urine and splenomegaly, because the spleen is now hyperfunctioning to break down all those red blood cells. Unconjugated bilirubin is then conjugated in the liver to a less toxic substance. And so, because of the high amounts of unconjugated bilirubin, the liver starts to hyperfunction, and that leads to hepatomegaly. And we will also see some skeletal changes in people with sickle cell anemia due to extramedullary hematopoiesis, which just means that because of the hemolysis of red blood cells, the body tries to produce more and more red blood cells to compensate. And the red blood cells are produced in the medulla of bones. So the medulla of these bones begins to expand, resulting in expansion of the bone itself. So examples of skeletal uh, ah, so examples of skeletal changes include chipmunk facies, which occurs due to enlargement of the maxillary bones, as well as hair on end appearance on the X-ray of a skull. So now we'll move on to the signs and symptoms caused by vaso-occlusive crisis. Simply put, vaso-occlusive crisis occurs when red blood cells clog the capillary beds present all over the body due to their sickle cell shape. First of all, we have acute chest syndrome, which occurs due to microinfarctions as well as pneumonia and even fat embolisms. So if you look at this CT scan of the chest here, you can appreciate bilateral basal opacities in both lungs. In the spleen, vaso-occlusive crisis can lead to splenic sequestration, which means that the sickle cells they become trapped in the spleen, resulting in painful splenomegaly. And you should be able to appreciate in this CT scan that the spleen is enlarged. Autosplenectomy can also occur due to vaso-occlusive crisis, in which the sickle cells cause occlusion, and the occlusion leads to ischemia. The ischemia in turn leads to infarction, and because of the infarction of the spleen, functional asplenia occurs, which means that the spleen stops functioning. Then in the kidney, vaso-occlusive crisis can lead to renal papillary necrosis. So if we zoom in here on the kidney, this area here is a papilla, which is where the urine from collecting ducts is drained into the pelvis of the kidney. So, and if you look here a bit more closely, you might be able to appreciate that the blood supply of the kidney is such that the outer cortex receives all of the end capillaries, and the central medulla is further away from these end arteries. And that is why the medulla is susceptible to ischemia, and so are the structures that are present inside the medulla, such as the papillae. So, due to renal papillary necrosis, the kidney is then unable to concentrate urine, and then you might also have hematuria, either gross or microscopic. And the end result of renal papillary necrosis can be end stage renal disease. So, moving on to the bone, vaso-occlusive crisis can cause avascular necrosis of the femoral head because of its unique blood supply. And it can also lead to osteomyelitis, which is caused by the Salmonella typhi bacteria, which, by the way, is an encapsulated gram-negative bacteria. And then we also have pain crises in patients with sickle cell anemia. So to help you understand better, we'll use the modified Socrates criteria to explain the characteristics of the pain. So S for sight, you might have the pain in your back, your knees, your legs, arms, chest, or stomach, so pretty much anywhere. So O for onset, acute painful sickle cell episodes can occur unpredictably. T for timing or frequency, the frequency varies from less than one episode a year to even at least once a week. And then C for character, the pain can be throbbing, sharp, dull, or stabbing. And then E for exacerbating factors, the pain may be excruciating, often without clear precipitating factors. And finally, S for severity, the pain can fluctuate in severity. So what I'm trying to show here is that pain crises in sickle cell anemia can be very variable in many number of ways. So now we'll move on to how to diagnose sickle cell anemia. Firstly, we'll look at a simple full blood count. The RBC count would decrease because of hemolysis. The hemoglobin count would also decrease, and so will the hematocrit. However, the reticulocyte count would increase because the body is now producing red blood cells at a faster or higher rate. And that's why the immature red blood cells, which are the reticulocytes, would increase in number and percentage. Then we can also do a sickle cell screen. Here, what we do is that we add sodium metabisulfite to a test tube containing blood, and that creates an oxygen deficient environment by reacting with the oxygen. And an oxygen deficient environment is supposed to induce sickling if hemoglobin S is present inside the test tube. And if sickling occurs, you can see that the test tube becomes turbid in appearance, such as here. Then we can also do a peripheral smear where we can look at the sickle cells under a microscope. And finally, to confirm our diagnosis, we can use hemoglobin electrophoresis, which not only allows us to identify hemoglobin S, but also quantify it. And that is important because sickling will only occur in people who have a concentration or a percentage of hemoglobin S of greater than 60%. In sickle cell trait, you have a much lower percentage of hemoglobin S, and so the people with sickle cell trait will not have the sickling or the symptoms which are caused by sickling. Whereas people with sickle cell anemia will have a much higher percentage of hemoglobin S, and that is why the sickling will produce signs and symptoms, as we've discussed earlier. So now we move on to the management. First of all, some general steps of management include folic acid supplementation up to 400 micrograms daily, and that's because the body needs folic acid to produce the red blood cells to compensate for the hemolysis. Antibiotic prophylaxis with phenoxymethylpenicillin is also given for children up to the age of 5. Vaccinations are also needed against the encapsulated organisms because the spleen is now not functioning really well. And without the spleen, the body is more prone to infections by encapsulated organisms. And these organisms include pneumococcus, meningococcus, Haemophilus influenzae, hepatitis B, and influenza, which is the flu. Malaria prophylaxis may also be necessary for those who are traveling to endemic areas. And even though I mentioned earlier that sickle cell trait gives you resistance to malaria, sickle cell anemia does the opposite. Because in sickle cell anemia, you will have decrease in hemoglobin, and malaria will only make that hemolysis even worse. So you must remember that sickle cell trait is what produces the resistance, but not sickle cell anemia. Surgery is also an option for those who have avascular necrosis of the femoral head or splenic sequestration. DVT prophylaxis is also warranted for people with sickle cell anemia who have been admitted in the hospital. And DVT prophylaxis can just include anticoagulants such as low molecular weight heparin. Now moving on to management of the pain crisis that is seen in patients with sickle cell anemia. So the most important thing is rehydration, because rehydration with IV fluids will lead to decrease in blood viscosity, which reduces the chances of sickling in the blood. And we must always remember that for an average person, fluid intake should not be more than 3 liters in 24 hours. Then, of course, for pain, you would need analgesia. So the way that we give analgesia is that if the pain is mild or moderate, which means that the pain score is under 7, oral analgesia is given, which includes different formulations of morphine and oxycodone. And if the pain is severe, having a pain score of more than 7, then slow intravenous or subcutaneous morphine and oxycodone are given, preferably via a patient-controlled analgesia device. And then always remember to prescribe paracetamol and NSAIDs with these analgesics if the urine dipstick and glomerular filtration rate is normal. And always remember to prescribe adjuvant medications along with the analgesics, which include antiemetics such as ondansetron, antipruritics such as chlorpheniramine, and laxatives. And then we have another medication that is used for treatment called hydroxycarbamide, which might also be known as hydroxyurea. And hydroxycarbamide or hydroxyurea is only given for patients having more than 3 episodes of pain crisis in a year. And the way that it's given is that you need to titrate the dose for hydroxycarbamide for the first 6 months. And by the end of 6 months, when you find out the optimum dose that the patient needs, you just continue him or her on that dose for the rest of their life. The reason why hydroxycarbamide or hydroxyurea is used is because it promotes the formation of hemoglobin F. And hemoglobin F has a much higher affinity to oxygen than hemoglobin S. And that's why it's much harder for hemoglobin F to sickle as compared to hemoglobin S. And finally, exchange transfusions are also used to help in relieving symptoms associated with pain crisis and sickle cell anemia. And the way that works basically is that you remove 2 units of blood from a patient in sickle cell anemia, which is obviously going to include the sickle cells and hemoglobin S. And then you replace that with 2 units of blood transfusions which do not contain hemoglobin S or sickle cell, thereby decreasing the percentage of hemoglobin S inside the body. And that was it for this video. These are some of the references that I used, and I think that you will find them useful as well if you want to go through the management, particularly of sickle cell anemia. Thank you so much. I hope you learned something from this video. I'll see you next time on sqadia.com.